Welcome to Off-Site Physician Offices Integration, a presentation for the course Introduction to Purchasing, PSPM 5240. The team responsible for today's presentation is David Sarcopski, David Griles, and Donna Rose. Today we will talk about a make-or-buy decision centered on the technological integration of 5 physician offices newly acquired by an established hospital. The acquiring hospital currently utilizes a legacy hospital management system different from the 5 physician offices. The hospital needs to make a decision whether to extend the legacy software and convert the new offices to the legacy system using internal resources, the make choice, or to outsource the physician office's management and software to an outside vendor, the buy choice. Before we begin our discussion, we will start with a review of make or buy decisions. According to the text, Procurement Principles and Management, make or buy decisions are decisions made about the source of materials, goods, or services. At their heart, make or buy decisions are choices between expending resources to make something within the organization or expending resources to purchase the item from a vendor. Whether to produce these items in-house using organizational resources or acquire them externally is dependent upon a number of factors and can involve both tactical, short-term considerations and factors that take into account the long-term strategic considerations of the organization. Make or buy decisions are based on a number of factors. A key factor involved in the make or buy decision is the cost to produce the required item in-house versus the cost of acquiring the item from an external vendor. Another key factor is whether the activity required to produce the item is an activity that is considered core to the business model of the organization. Work to produce an item that lies outside the core competency of an organization is ideal for outsourcing. Also, an additional factor is whether the organization believes that it is important to maintain in-house competence in the production of the needed item. If so, the organization is less likely to acquire the item from a vendor. A final factor favoring in-house production is the need to maintain confidentiality or secrecy. Factors that favor outsourcing include whether access to specialized skills and equipment not currently available in-house are necessary, and the ability of the organization to take advantage of resources freed up by outsourcing. We will begin with a review of the situation the hospital finds itself in at the beginning of our scenario. As the main platform for hospital operations, the legacy software system is used by the entire organization for both patient record management and business operations. The newly acquired off-site physician offices have a different management system. As a result of the merger, it is imperative that the newly integrated physician offices be integrated into hospital operations. Therefore, it is necessary that the physician offices and the hospital be able to seamlessly share information on patients and operations. To obtain this level of integration, both the administrative and clinical staff need to be included in the integration effort. Also of importance to the success of the implementation is the requirement to make the system accessible to all relevant stakeholders, including patients, medical staff, and administrative staff. This helps to close all of the gaps concerning a patient's continuity of care. Finally, maintaining the stability and control of patient information records are of critical concern within a patient care environment. In the initial review for the make or buy decision, several issues connected to an outsourced solution were identified. Support contracts currently in place in the off-site offices would require updating as new requirements are identified. Also, vended solutions of the type used in physician offices typically lack the robustness to handle requirements of hospital billing, making integration difficult. Additionally, the hospital lacks a relationship with such a vendor, requiring the hospital to evaluate the vendor's abilities to handle the integration successfully, requiring potentially significant expenditures on researching the market to locate a suitable vendor. Also, the vendor may suggest conversion to a different system from the one currently implemented by the hospital as necessary and/or preferable to integration, requiring a significant new investment that the organization may be unprepared to make. Alternatively, a custom transmission system for patient information would need to be written in-house, delaying the project and diverting resources. Additionally, an outsourced system would require updating and additional testing of both systems to ensure successful integration, slowing progress and diverting resources. Also, all current hospital staff would require training on the new vended system, requiring a significant training effort. The addition of a second system could also create fragmented user information across the two systems, slowing delivery of services as practitioners switch between systems. Finally, the additional vended system would require the acquisition of additional tools to generate necessary reports, tracking information, key metrics, and other needed analytics required by the hospital and its stakeholders to successfully manage operations. Several advantages of an in-house approach were also identified during the initial review of the make or buy decision process. Patient information would be centralized onto one platform maintained by hospital IT and clinical informatics departments. This would eliminate the need to duplicate information into two systems and simplify information maintenance. Additionally, testing and maintenance would require fewer resources and would be able to be performed more quickly as only a single system would be involved, eliminating the need to test interoperability. Additional resources are also saved as the need to develop interfaces between the two systems is obviated, saving the two technology units significant time and reducing costs. Training is also simplified and costs are reduced as training on a singular system requires fewer resources to be allocated than training on multiple systems. Additionally, most employees would require little or no retraining, with the bulk of training being concentrated on the employees of the newly acquired off-site locations. Additionally, departments that are at higher risk of the negative impacts of process changes, customer service, coding, and billing departments, would experience minimal impact when implementing an in-house solution. Another of the identified advantages of performing the integration in-house is the established relationship with the current vendor. This relationship eliminates uncertainties and concerns along with the resource expenditures that go hand in hand with the selection of a new vendor. Another advantage of this relationship that would support an in-house solution is the excellent support that the vendor provides as part of the existing contract. This support should ease the burden of the in-house staff's efforts to fold the new off-site locations into the extant system. Additionally, Adding a location in a legacy hospital system is a low effort and cost activity as compared to purchasing and implementing a vended system. Additionally, the increase in the number of sites can lead to a lower cost per site due to bulk pricing. Finally, as the team is familiar with the software and with upgrade planning and implementation pathways well established, cost and efforts dedicated to this function are minimal. In summary, in addition to the weaknesses previously noted, the outsourced solution carries significant strengths as well. Buying the vended solution would allow the technology units to maintain focus on supporting the hospital needs rather than incorporating the smaller off-site locations. The vendor has a deeper understanding of the vended solution than the in-house staff has of the current hospital legacy software solution. This may allow the vendor to provide a more tailored solution. And the vendor has direct access to the developers of the vended solution, allowing enhanced troubleshooting and input into future development. However, these strengths are outweighed by the numerous weaknesses. Among them are the additional burden of maintaining two systems, the need to develop interfaces between these two systems, the potential for data fragmentation, reporting needs of the organization, high cost of training requirements, and the high cost of the software itself. In addition to the strengths previously noted, the in-house solution carries significant weaknesses as well. Needed software features may be delayed as the IT and clinical informatics staff concentrates on integrating off-site locations. The in-house team may face challenges such as special billing practices, which may be difficult to reproduce within current software constraints. Additional support resources from the legacy system vendor may be necessary, risking cost overruns. And in order to complete the project within a reasonable time frame, staff may be required to work overtime, incurring significant additional costs. However, these weaknesses are outweighed by numerous strengths. Key among them are cost savings and ease of use of having a single system, expertise within the organization with the current system, ensured integrity of patient records, minimal staff impacts, positive relationship with current vendor, and providing a low-cost solution. Schwarting and Wiesbarth, in their 2011 article, Make or Buy, Three Pillars of Sound Decision Making, describe a framework for weighing the various factors in making a make or buy decision. The authors point out that the effects of these decisions extend beyond the immediate concerns of production of the particular material, good, or service in question, but can deeply affect the organization's other key activities, such as human resources, information technology, and other functions, both positively and negatively. Schwarting and Wiesbarth framework is based on three pillars: business strategy, risks, and economic factors. We will now examine each of these pillars in turn and their implications for the project under examination. The first pillar, business strategy, concerns the strategic importance to the company of the service or product that is being considered for outsourcing. Those services or products deemed important or core to the company should be carefully reviewed before outsourcing. In addition, those technologies required to produce those services or products considered core should likewise be carefully considered before outsourcing. Additionally, a review of both the current and future environment should be considered as well. We will now look at how this pillar, business strategy, relates to our example of integrating the physician offices into the hospital legacy software. All patient management and business operations in a hospital flow through the legacy management software system in a way that works well in the current environment. This high level of operation helps to maintain satisfaction among hospital customers, allowing for customer retention and business growth. Clearly, the hospital views its legacy software as core to its organization's success and should therefore carefully weigh any decision to outsource any related activity, such as the physician office's software. Additionally, provided an in-house solution for the incorporation of the physician's offices should ease any future similar transitions, allowing the hospital to be in a better position to take advantage of future opportunities. According to Schwarting and Wiesbarth, the second pillar are the risks related to outsourcing. These risks stem from uncertainty related to supplier operations. Without direct control over production, the buyer runs the risks of receiving inferior goods. Additionally, suppliers can become unreliable and act in unpredictable ways. While this can be mitigated somewhat by carefully identifying and selecting suppliers along with establishing a good ongoing relationship with the vendor, difficulty and uncertainties in these processes still remain. This pillar also holds implications for our hospital scenario. Uncertainty with the quality and capabilities of a vended solution risks customer dissatisfaction if it fails to be fit for purpose. Also, staff may have difficulty in adapting a new solution. Additionally, the hospital will have to engage in a new relationship with the software vendor, which may require a significant time to build itself into a successful partnership. The hospital also places itself in a potentially riskier situation by having to delay needed enhancements and features while the off-site locations are being integrated. The third pillar, according to Schwarting and Wiesbarth, consists of the economic factors surrounding the project. Some of these factors include capital expenditures, return on invested capital, return on assets, and savings due to outsourcing. Additional factors include administrative costs and expenses from delays, along with differences in productivity and labor costs between in-house and outsourced work. Several economic factors are found in our example project. Cost overruns on in-house production are possible during integration due to exceptional cases, such as special billing procedures. These situations can lead to increased overtime to accomplish the work, lost opportunities on other activities as staff are reallocated, and increased cost for contracted support hours. On the outsourcing side, the vended solution may not have all of the necessary functionality, requiring additional effort and time to recreate functionality in the vended system that already exists in the legacy system. Additionally, the necessary retraining may slow operations and decrease quality, leading to lost opportunities. Ultimately, the preponderance of factors led to the decision to perform the integration using internal resources, integrating the physician's offices into the legacy hospital system. There were several factors in support of this decision. The hospital's information technology and clinical informatics departments are viewed as having all of the necessary experience and expertise to accomplish the integration in-house. A singular management system was favored over dual systems due to reduced complexity. The legacy management software was seen as a core activity central to the hospital's business strategy, making it an unlikely target for outsourcing. In-house integration was seen as lower risk due to the long-established relationship with the current support vendor. Finally, the estimated cost savings by staying in-house were large, as the vended solution was approximately 9 times the cost of the in-house solution. With the decision to make the solution set, the project plan was completed. Project objectives were finalized. The plan called for integrating the 5 new facilities into the main legacy platform currently in use by the hospital, building and configuring each of the locations to properly interface with the hospital system. All clinical and administrative staff will be integrated into the system. Finally, a goal of 100% system stability and full control of the off-site locations is set. With the project objectives set, the project team, consisting of information technology and clinical informatics staff, chose the approaches to be taken during the project. Clinical informatics was chosen to lead the team. Starting with the electronic health record, the clinical informatics team will progress through the patient registration and financial subsystems. Upon completing the code and translation table, validation by clinical informatics, clinical and administrative staff will begin, ensuring information is successfully flowing through the system while remaining accurate and unaltered. As the build and configuration of the system will be handled internally, the effects of integration on the hospital support contract is expected to be limited. This will allow the current contract to remain in place during the integration, providing a backstop for unexpected roadblocks discovered during the integration process. However, it is imperative that the clinical informatics staff monitors the usage of support hours to ensure that the project does not incur additional support charges. The following resources were used during today's presentation. This concludes today's presentation. Thank you for your attention.